Welcome to the VJHemOnc podcast. We recently attended the 2025 ASCO Annual Meeting in Chicago, Illinois, where leading experts gathered to present the latest breakthroughs in oncology and hematology. In today's episode, we're bringing you key highlights from the meeting across multiple myeloma, lymphoma, myeloproliferative neoplasms, and BPDCN. Let's begin with insights from Dr. Claudio Cerchione, who shares important updates in multiple myeloma. He discusses ongoing clinical trials, the potential of subcutaneous isatuximab, novel cellular therapies, and treatment strategies for difficult-to-manage patients.
It has been a brilliant ASCO 2025 in Chicago for myeloma researchers and patients. We have seen a confirmation of several data in terms of MRD negativity in transplant-eligible and not eligible frontline patients, particularly from ISCI and Perseus in transplant-eligible and Cefeus and IMBROS in transplant-ineligible patients. And I think that the new ambition will be more and more to obtain MRD negativity as a real endpoint in frontline patients. In terms of relapsed refractory patients, we have seen many confirmation. I think the outstanding data comes from CARTITUDE-1 trial, which we have seen 33% of progression-free survival at 5 years. In my opinion, this is an outstanding data if we consider the setting and the characteristic of a patient. Another really brilliant opportunity is the subcutaneous administration of isatuximab. We have seen a couple of trials. It's ALCO phase 2 in combination with the carfilzomib and dexamethasone, and Heraclea phase 3 in combination with the POM and dexamethasone. To Heraclea, we have collaborated with many patients from my institution, and I think the idea of non-inferiority in terms of effectiveness, but superiority in terms of comfort and quality of life makes the subcutaneous administration of isatuximab a wonderful opportunity for our patient that should be integrated as soon as possible also in the new triplet that we are going to use in our frontline patient and not only in the combination in relapsed refractory. Isatuximab is becoming more and more an important backbone in the fight against multiple myeloma. What about the novel cellular therapies? We have seen not only CARTITUDE-1 but also bispecific antibodies, incredible data, new combination with elranatamab and linvoseltamab, particularly I appreciate the combination with the carfilzomib. Maybe we can imagine to extend to new generation studies in order to confirm the idea of combining BCMA, CD3 bispecific antibodies with the carfilzomib also in phase 3 trial. We have seen an indirect analysis of linvoseltamab versus elranatamab with the superiority of linvoseltamab. So I think that the best has to come in order to understand which is the best in terms of effectiveness and tolerability. And I think that also we have seen incredible data from real world. Bispecific antibodies are showing their feasibility also in community center in terms of effectiveness, tolerability, and management. And I think that in this moment they are really concrete in helping us to treat also really difficult to treat patients. What about really difficult to treat setting of patient? We have seen belantamab mafodotin in combination with bortezomib dexamethasone DREAM7 sub-analysis in high-risk histogenetic patient. And I think this data are really brilliant, and we are in front of a potential new standard of care in second-line patient affected by multiple myeloma. We have seen also really nice analysis in terms of profilation of our patient. Also from our institution, we have shown data in combination of whole body MRI with the PET-CT and the new molecular analysis with SKY92 with the series of multi-omic analysis, with the idea of developing a prognostic score which helps us to optimize the management of our patient affected by smoldering multiple myeloma frontline or relapsed refractory setting. All these novelties tell that ASCO has become an important appointment for hematologists, particularly for myelomologists, and I think that considering all of the novelties that we are going to see month by month, conference by conference, the cure of multiple myeloma is not far anymore, and this is the best wish that we give to our patient, to their caregiver, and to all myeloma researchers.
Next, we hear from Dr. Andrew Kuykendall, who provides an overview of key developments in the MPN landscape. He highlights results from the phase 3 VERIFY trial, evaluating rusfertide in polycythemia vera, and the IMPROVE-MF study, exploring imetelstat in combination with ruxolitinib for myelofibrosis. He also discusses broader practice-changing insights from ASCO 2025, including findings from the VERIFY and SURPASS-ET.
The phase 3 Verify study was a study looking at the agent rusfertide in patients with polycythemia vera who were requiring consistent phlebotomies. It's an agent that we looked at in the phase 2 Revive trial. And in that trial, we saw that rusfertide had the ability to decrease phlebotomies and control hematocrit in patients with polycythemia vera. This is a treatment goal of ours in patients with polycythemia vera because we know consistent control of hematocrit correlates with a decreased thrombotic risk. Patients with polycythemia vera oftentimes are overproducing blood cells, and we have to do recurrent therapeutic phlebotomies, whereby we drain them of their blood repeatedly over and over to achieve this hematocrit goal. Unfortunately, this often makes people feel quite terrible with their disease and often ties them to the healthcare system because they're having to come back in for consistent or recurrent phlebotomies. We aim to use our understanding of the iron regulation system, if you will, to try to better control hematocrit utilizing an agent called rusfertide, which actually is a mimetic of a protein called hepcidin. Hepcidin is like the master regulator of iron homeostasis in the body and actually decides if iron is distributed to the bone marrow for continued red blood cell production. Hepcidin really acts in settings of low iron or iron deficiency, whereby hepcidin is downregulated and really allows iron to freely flow to the bone marrow for more red blood cell production. The problem lies in the fact that polycythemia vera patients are making too many red blood cells, but they're also iron deficient. And so all the iron they do absorb goes right to the bone marrow for continued red blood cell production, and we have to then tackle that with more phlebotomies. Instead, we decided let's tackle this with a mimetic of hepcidin called rusfertide. So in these patients, rusfertide actually causes iron to not be delivered into the blood and not be given to the bone marrow, thereby controlling red blood cell production through the restriction of iron through the provision of rusfertide. So in this phase 3 trial, we took patients that had polycythemia vera who were requiring phlebotomies and randomized them 1-to-1 to receive placebo versus rusfertide in addition to their current standard of care. And the results were quite interesting. We found we were virtually able to eliminate the need for phlebotomies in these patients, consistently control their hematocrit, and also what we saw was really interesting was it had the ability to improve disease-related symptoms, specifically things like fatigue that can be quite plaguing for these symptoms that live with this disease for a long time. So in summary, what we saw from Verify was an agent that can be given, get rid of the need for phlebotomy, get people away from the healthcare system, give them a bit more freedom back, and potentially improve their symptoms. And hopefully this data will support using this as an approved agent in the near future. So IMPROVE-MF is really looking at an agent called imetelstat. This is approved for MDS right now in patients that have significant anemia, but we're interested in myelofibrosis as it's shown some potential to be disease modifying. In the phase 2 study that looked at imetelstat in patients with relapsed refractory myelofibrosis, we actually saw patients lived a bit longer than we thought they would in an especially challenging group of patients. So the IMPROVE-MF actually takes that now back to a phase 1, but uses it in combination with ruxolitinib. We know many of our patients really do need a JAK inhibitor on board. And so the idea of using something that could be disease modifying, in addition to something that certainly helps with the disease-related symptoms in splenomegaly, is something we're quite interested by. It's an early phase study right now, but what we've seen is this is a safe combination and has the ability to really provide enhanced disease control. So we're excited about kind of finishing the phase 1 study, expanding that out, and then further studying this in later phase studies. I think there's two main practice-changing things in myeloproliferative neoplasms at ASCO this year. The first of which is the Verify trial, which we presented as a late-breaking abstract in the plenary session today. This is looking at rusfertide as an ability to reduce the need for phlebotomy in patients with polycythemia vera. In addition to that, what we're going to see is a clinical trial looking at ropeg interferon in patients that have essential thrombocythemia, or ET, called the SURPASS-ET study. We often use interferons in patients that have ET, but we haven't been able to use ropeg interferon to this day. And so ropeg interferon was looked at as a second-line agent in the treatment of patients with ET randomized against anagrelide, and we saw superiority of the ropeg data against anagrelide in these patients with essential thrombocythemia. This now allows us to have that option for these folks. Right now, ropeg is already approved for polycythemia vera, but to be able to use it in our ET patients, I think will come with as a welcome addition.
In the next section, Dr. Manali Kamdar shares key updates in non-Hodgkin lymphoma and chronic lymphocytic leukemia. She discusses major trial data presented at ASCO, including the STAR-GLOW trial in relapsed refractory DLBCL, Arm C of the Sequoia trial evaluating zanubrutinib in CLL, and the Simpatico study examining ibrutinib plus venetoclax in treatment-naive mantle cell lymphoma.
So in terms of lymphoma, I think some of the long-term follow-up data comes to mind, for example, the one that Dr. Abramson presented on the STARGLOW study, which was in patients with relapsed refractory DLBCL, ineligible for a transplant, randomized to HemOnc versus GemOx plus glofitamab. And this was a 2-year data set, which showed that on the glofitamab GemOx arm, which is the arm that showed a significantly superior PFS as well as overall survival. Important to underscore that the overall survival benefit maintains. More than 50% of patients continue to be alive. And in patients who achieved a complete response, the overall survival was excellent, obviously, but also the PFS was not reached. So another way to potentially take care of our patients who may not be able to get to CAR, either because of logistical barriers or socioeconomic barriers, or just because the disease is proliferative. So I think STARGLOW gives us a peek into that. The other study, I think, that looks at long-term data set is the one that was presented by Dr. Tam, the Sequoia, the Arm C, where zanubrutinib was explored and investigated in patients with deletion 17p or TP53 aberration CLL. And really heartening to see that at the 5-year mark, both the PFS as well as the overall survival is, looking very good. 5-year PFS is over 70%. No new safety signals were seen. And interestingly, they also have published zanubrutinib outcomes in patients without deletion 17p. And it's very intriguing to see that there were no differences between deletion 17 and non-deletion 17p enriched CLL patients. That really goes on to show that zanubrutinib can abrogate the adverse events of deletion 17. In terms of other data sets that caught my attention, I think it was a Simpatico study that was presented by Dr. Michael Wong in untreated patients with mantle cell lymphoma, either older or with TP53 mutation. And so far, it looks very durable in the non-TP53 mutated population and the younger population with TP53 mutation. Simpatico explored ibrutinib plus venetoclax for 2 years, followed by ibrutinib indefinitely. More than half of the patients did discontinue one or the other drug, but I think it was a very fabulous strategy to figure out and explore chemo-free options for patients who are high-risk mantle cell lymphoma. So I'm looking forward to getting some more updates on that study as the study continues to mature.
You will now hear from Dr. Constantine Tam, who provides a deeper look into the 5-year follow-up data from Arm C of the Sequoia trial. He focuses on patients with deletion 17p CLL, commenting on the long-term progression-free survival and what these results could mean for the future of CLL treatment.
So the study today is really about the long-term results of zanubrutinib in patients with 17p deletion CLL. So prior to this, 17p deletion CLL is a horrible disease to treat with very poor treatment outcome. And there are smaller studies with acalabrutinib and ibrutinib to suggest that these patients do well in the medium term. But what we have in the Arm C of the Sequoia study is actually the largest collection of patients with 17p disease treated uniformly with a single drug, which is zanubrutinib. So this is 110 patients in total. They all have 17p. They all receive zanubrutinib, and we now have 5 years follow-up from those patients. So the key result is that we have a 5-year progression-free survival of 72.2%. Now, to put this in context, if you compare this against the other arm in Sequoia, where patients without 17p were treated with zanubrutinib, that progression-free survival is 75%. So really 75% without 17p, 72% with 17p. I think what that largely shows is that zanubrutinib is able to neutralize the very adverse risk of this previously very hard to treat disease. So I think there's an immediate practice application to this. And that is that if you have a patient with 17p deletion CLL and you need to treat them, that the best information and the best data is with zanubrutinib at this point in time. The future directions are how to use zanubrutinib or similar BTK inhibitors in limited duration therapies to further improve the outcome of 17p disease without having the patients to take drugs long term. So we are doing those studies where patients are being given combinations of zanubrutinib and a BCL2 inhibitor in limited duration, and we're hoping to achieve equally as good results, if not better, without having to subject patients to long-term treatment.
Finally, Dr. Naveen Pemmaraju presents updates in BPDCN. He discusses new data from the Cadenza trial, evaluating pivekimab sunirine, and outlines emerging strategies targeting CD123, BCL2, and other promising combination approaches.
I'm really delighted to be here at ASCO on behalf of my co-authors to talk about the pivekimab sunirine study, which is a Cadenza study for patients with BPDCN. So briefly, pivekimab sunirine, or PVEC, is a CD123 antibody drug conjugate. So this new agent is designed to help treat patients who express that target, CD123, and it turns out BPDCN, it's 100% of the time. So that's the background. We then sought out to do what turns out to be a very large prospective study in our field, 84 patients overall, of whom 33 patients are frontline, and out of those 20 are the key analysis group or primary analysis population. So briefly, what we found with this IV drug every 3 weeks can be given outpatient is it was very safe and well tolerated, no capillary leak syndrome events, which does happen in some CD123 expressing agents. And the overall results were very promising, very encouraging. What we found is an overall CR/CRc rate, so complete remission rate of 70% in the frontline primary analysis population of those 20 patients. The overall response rate was even higher. In the relapse refractory group, which is a heavily pretreated high-risk group of patients, we also found an encouraging response rate. In the frontline setting, the median overall survival was 16 plus months, which is very good for this historically poor prognosis tumor. As I mentioned, it's a safe, well-tolerated drug. You do have to look out for peripheral edema, which we saw in 3/4 of the patients, and infusion-related reactions. So overall, we conclude from the Cadenza study, PVEC for BPDCN, that we have a novel CD123 ADC targeted agent, well tolerated, and could potentially represent a practice-changing paradigm for our field. So keeping on the theme of BPDCN, the excitement is building in our young emerging field. It was just not that long ago where people couldn't pronounce the name of our disease or had never really heard of it. So I'm proud of the international efforts of our community to put BPDCN on the map. With that, I think I would break it down into 3 exciting areas. One, as you're seeing here at ASCO from my group and others, is targeting CD123. So after the tagraxofusp agent, which is already approved, and the one in the later stage development that we're also presenting here, the pivekimab sunirine, I look forward to seeing other CD123 targeted agents developing in all the different ways possible: CAR T cells, bispecific, monoclonal antibodies, you name it. A second area is beyond CD123. Our group and others have shown the activity of targeting BCL2, and so that has opened up a brand new pathway in BPDCN, and our group has published widely on that. And then finally, beyond even CD123 and BCL2 is combinations. So we've only been talking about monotherapy this time, but I'm quite excited about the prospect of combination therapies. And we have several of those trials ongoing. They're publicly available, registered on clinicaltrials.gov. And the concept there is, can you take multiple of these pathways? So one clinical trial we have, for example, is combining CD123 hypomethylating agent and BCL2 targeting. Yet another one is CD123 cytotoxic chemotherapy and BCL2 targeting. So you're starting to see those combinations. And finally, we need to think about central nervous system disease treatment and penetration, because this rare tumor, BPDCN, unfortunately has a predilection for central nervous system involvement, so we need to be targeting that as well.
Thanks for tuning in to this special ASCO 2025 highlights edition of the VJHemOnc podcast. For more expert insights, follow us on X at VJHemOnc and subscribe to our podcast on Spotify, Apple, or Podbean. See you next time.